Hi, I'm Maen Abdelrahim, Chief of GI Medical Oncology and Medical Director of Phase 1 program at Houston Methodist. Today we're going to discuss an important and evolving topic in oncology in general and GI oncology specifically, which is a ctDNA, role of ctDNA in GI oncology and transplant oncology. ctDNA basically is a circulating tumor DNA. It's a small DNA fragment derived from the tumors. When the tumor developed and grow, this DNA or fragment of DNA get into the circulation through multiple processes. That include apoptosis, necrosis, and secretion. And sometimes the cancer cells into the blood circulation will die and secrete a piece of DNA into the circulation. This DNA in the blood is a very valuable tool for many purposes in GI oncology. For example, this DNA can be taken out in a blood test we call liquid biopsy. That liquid biopsy, when we get the blood, we spin it down and it's separated into three layers: the RBC layers, the leukocyte layers, and the plasma layers. The plasma layers is the one that have the DNA in it. And this DNA, once we get it in this plasma layer, we do some analysis and testing, and that will help us to find out first MRD, which is a minimum residual disease. Basically, do we have a DNA after a curative surgery or a transplantation? That's going to help us to make a clinical decision of giving a treatment after surgery or a curative surgery or not. The second use of this ctDNA is actually surveillance. After the cancer is resected and the patient is cured, we do a surveillance for the life of the patient, roughly around 5 years. And this can be an important tool to tell us, does the cancer come back or not? This is a clinical decision we made based on that to involve in another surgery or involve systemic treatment or radiation. The third utility of it is what we call it NGS. NGS is next generation sequencing or molecular profiling. This piece of DNA in the blood can give us information about the mutation or alteration in the tumor. We live in the era of precision oncology. So knowing the tumor, molecular profiling help us to decide what's the next treatment available for the patient. And we're going to discuss this a little bit. The fourth utility of it is treatment response. Sometimes we do a scan every 3 months, but if we have a tool or a biomarker that can tell us is the treatment working nicely or effectively or not, that will help us to make an earlier decision to switch treatment or continue the same treatment. So ctDNA in the blood is a dynamic quantitative test, can tell us more about treatment response, and that's going to be used in these scenarios. So most of our data for ctDNA is actually came in from colorectal cancer. But at our institution here, we start thinking beyond the colorectal cancer. We start investigating for pancreatic cancer, liver cancer, cholangiocarcinoma. And today we're going to discuss only one topic for the sake of time on liver cancer. As we know, liver cancer is the 6th most common cancer worldwide, and it is responsible for harvesting of many of patient life. It is the most common primary liver cancer, which is HCC carcinoma, and it can be cured in a way that can taken out by surgery or can be transplanted or have a local regional therapy to treat it. For surgery, even though it's a curative, the cancer come back, and there's a coming back up to 40 to 60% of the cases. For transplantation, the cancer can come back up to 20 to 25%. So imagine a patient, you go through a major surgery, resection, or transplantation, and 1/4 of those patients after transplantation are going to come back. So it will be really important and key in the patient management to know who's those patients going to have a recurrence of a disease after the surgery. So we can detect those patients, we can have an early decision about their management. The way we look after curative treatment or do surveillance for those patients after curative treatment is we do scans every 3 months, and sometimes there's a marker called alpha-fetoprotein, and that is a protein secreted from the cancer. We usually detect this test in the blood, but alpha-fetoprotein have its own problem, and even the scan have its own limitations. So alpha-fetoprotein have a low sensitivity and specificity for the cancer. It can have a false positive in a certain situation, and it can have a false negative when the cancer is so small or the cancer does not secrete alpha-fetoprotein. So it will be crucial to have a test beyond the scans, on beyond the blood test like alpha-fetoprotein, where we can detect cancer recurrence and minimum residual disease after that. So we're going to focus on surgical resection and transplantation. We are the Methodist. We are #1 transplant cancer center in the country. We have a high volume, high outcome as well. So we start focus on those patient population who have a surgery or a transplantation for liver cancer in a cirrhotic patient. In general, ctDNA in liver transplant is evolving, and now it's been used or investigated in a different category. For example, sometimes we can use ctDNA for diagnosis and screening. ctDNA can be used for treatment response evaluation. If we give the patient a treatment before transplantation, it will be nice to know if the treatment working or not. So in the new adjuvant setting or bridging setting, ctDNA can give us information about the response to treatment. And finally, based on the NGS, we know if the patient have really a good biology or bad biology to select a recipient for transplantation. And this is actually new and evolving. But today we're going to focus our discussion on using ctDNA after transplantation. As we discussed, it's going to be MRD and also for surveillance. We're going to also look at response or no response to treatment in the adjuvant setting and surveillance setting. So the study we conduct at our institution is that for patients who have liver cancer, who can be resected or transplanted, those patients, we take a blood sample from them and we analyze it. The blood sample is taken at a different time point. The MRD time, which is up to 12 weeks from the time of surgery or transplantation, and the surveillance window, which is beyond the 12 weeks from the transplantation or surgery. Our methodology and the way we run our test, we use actually a precision medicine and a custom designed PCR assay to look for those patients and or the blood sample from those patients. How we do it? First of all, we do a tumor molecular profiling or analysis to get the signature of the tumor. And from that, we design a PCR assay. This is a custom designed PCR specific for each patient. And this PCR assay look for the top 16 clones in that samples from that patient. Then we use this assay to look for a DNA positive or negative in the patient population in the surveillance or MRD window. So this PCR is a custom design specific for a patient, is a personalized assay that is used later on in a blood sample from those patients at different time point to look for presence or absence of the DNA in their blood at a different time point after surgery or during the surveillance window. This table shows our patient population. In general, most of the patients are Child-Pugh A and B. And as you can see, we have the 3 cohort. Cohort A, which is we're going to discuss in a little bit, is a surgical resection. Let me take it back. Cohort A is a transplant patient actually, which is made up of 51% of the patient population. Cohort B is a surgical patient population, making around 41% of the patient population. And another cohort, which is a small cohort patient population, is a mixed bag between patients who have both relapse and for those who are unresectable, but they got ctDNA during their journey. This is basically cohort A, which is a transplantation. What you can see here, each line represents a patient. The white circle represents a negative ctDNA test. The green square represents a negative scan. And in cohort A, all patients have a negative ctDNA in the MRD window and even in the surveillance window. None of those patients actually have a recurrence of a disease. So that suggests the ctDNA test have 100% specificity. This is a cohort B, which is patients who have a surgical resection for their tumor, liver cancer. And same way, each line represents each patient. White circle is a negative ctDNA. Green square is a negative scan. Dark circle is a positive ctDNA, and red square is a progressing CT scan or MRI. In this cohort, actually, 30% of the patient have a DNA or ctDNA positivity in MRD window. As we speak before, the MRD window is up to 12 weeks from the time of the curative surgery. And we found that all those 30% patient who have a positive ctDNA in their blood in the MRD window, all of them have a disease recurrence. ctDNA can be a predictive and have a prognostic value in this setting. And if you look on the graph or the curve on the left side of the screen, we looked at the relapse-free survival. And as you can see, patients who have positive ctDNA have a decreased relapse-free survival compared to the patient who have a negative ctDNA, where they have relapse-free survival is way much better than compared to those patients. The hazard ratio for this study is really good, and we concluded that is from this part, that is in the surgical resection, ctDNA positivity can be associated with a poor outcome and worst relapse-free survival. This is the same cohort, but we look at a different window. It's a surveillance window, which is beyond the 12 weeks from surgery. And in this cohort, there's a 32% of the patient have a DNA or ctDNA positivity in the surveillance window. And all those patients who have positivity for ctDNA have a disease recurrence within that window. And we look at the relapse-free survival, we have similar story. As you can see here, patients who have a positive ctDNA in the surveillance window have a disease recurrence, and they have relapse-free survival worse than the patient who have a ctDNA negativity. And we did another study, which is around doing this test anytime during the journey of the patient and the cancer management. And again, we can see that is positivity of a ctDNA have a worse outcome compared to the negative ctDNA. So again, ctDNA in this way can be used as a biomarker and have a high prognostic value to tell us about a recurrence of a disease after a curative surgery. And this is positivity of a ctDNA in this window, surveillance anytime, and in the MRD window is associated with a worst relapse-free survival. The exciting news is that this test is a dynamic and quantitative test. We can do one test at one point and repeat the test at interval time, and this test can change up and down. This is important when you look for a response to treatment. Sometimes we lack markers, like alpha-fetoprotein is not always elevated, and sometimes the scan can be done every 3 months. But between this time, during the 3 months, it will be nice to know how is the treatment working. So this test, a ctDNA test, is a dynamic, and actually it can go up and down, depend on the response to treatment. In blue, you see these curves going down. That means ctDNA is going down, and that reflects a clinical benefit. Those patients or those group who have a ctDNA going down with the treatment, they have a benefit from the treatment, you can continue the treatment. On the other hand, in the green bars, this ctDNA is going up. That reflects that is during the treatment, ctDNA is increasing in the blood, which reflect lack of benefit of the treatment and maybe resistance to treatment and treatment failure. And at this moment, it will be the clinical decision to change the treatment even before you see it on the scan. What's also important is that we found that, during our clinical practice, when we have a ctDNA positivity, this is actually associated with decreased interval of the images. If we're doing the journey of the patient is on the treatment, and we're doing a ctDNA test, and the test become positive and positive, this will trigger us to do an earlier scan rather than waiting for the 3 months or 4 months sometimes. So the data have shown that is positivity of a ctDNA decrease the interval of imaging and may help us to make a clinical decision. We did a time-sensitive analysis. Basically, we looked at the lead time between the recurrence of a disease compared to the time when we see the positivity of the ctDNA or the alpha-fetoprotein. So the lead time again is the time between the positivity of the ctDNA or alpha-fetoprotein and the time we see it in the scan, or elevation or positivity of the scan, which is the relapse time. And this lead time is important, and we compare it between the ctDNA test, which is the interesting biomarker for us, compared to the alpha-fetoprotein, which is the old tumor marker that we used for many years. And we found that actually the lead time for ctDNA is 8 months, meaning that ctDNA positivity predicted the disease recurrence 8 months before we see it in the scan. While for alpha-fetoprotein, the lead time is 2.2 months. So that gives us that is ctDNA outperform alpha-fetoprotein in cancer detection and the lead time. This is very important because if you put your patient into a major surgery or a major transplantation, which is a major surgery as well, and the patient have a recurrence, it will be great to know if the patient have a recurrence early on time so you can intervene. Some of those patients, if we detect the cancer early on time, we can escalate their management. We can do a surgery, we can do an irradiation or local regional therapy for those patients, and the outcome is better. We call it oligometastasis detection in this case. So we discussed ctDNA, which is a tool that we used for MRD surveillance detection, response to treatment, but also circulating free DNA is another important biomarker that in a transplant world been used to detect rejection. So it can be used as an organ rejection tool. So patient who have an organ transplant, can be a kidney or can be a liver, those patients usually they have in the blood, they have their own free DNA or cell-free DNA, which is from the patient. In case of rejection, where there's an insult or an allograft rejection, you're going to start find the donor-derived ctDNA or cell-free DNA with the patient. So that means the donor DNA or cell-free DNA is in the recipient blood. That means there's the organ or allograft have some early sign of rejection. So it will be nice for those patients we treat for liver cancer by transplantation to have a ctDNA, circulating tumor DNA, detect recurrence of a disease early in time or during surveillance. But also from the same blood sample, we can look at the circulating free DNA and to evaluate, is the organ okay? Is there any sign of rejection? So one blood test tell you of a disease recurrence at certain time point, MRD or surveillance, also tell you about the health of the organ, of the transplanted organ. Is there's a rejection or no rejection, depend on the DNA test. So this is an evolving field and it's a very hot topic, and actually now in oncology and GI oncology, we call it a new field of a transplant oncology. Transplant oncology is a field of cancer care when the cancer can be treated by transplantation. Liver cancer, cholangiocarcinoma, or a neuroendocrine tumor can be treated by transplantation. And the evolving type of cancer now is colon cancer, that stage 4, liver-only metastasis that can be treated by transplantation. And it will be nice with increased indication for transplantation to have a biomarker that can detect early recurrence or that can detect recurrence later on in the surveillance. And this is actually a hot topic on now, which is transplant oncology. And we had actually published the first transplant oncology book, A Frontier in Multidisciplinary Cancer Care, where there's a 26 chapter in this book covering ctDNA, covering immunotherapy before transplantation and after transplantation. So the field is evolving and there's a lot to learn in the near future. It's exciting time in GI oncology and more to learn. Thank you.